Okay, we're going to move right to the discussion. Can our three additional panelists please come join us? Thank you. And as we adjust the stage, we have a series of questions that we're going to go through with the panelists and hopefully leave a little bit of time for interaction from the audience as well. Pretty busy place up here. Can we ask, starting with Ella, can we introduce the three new panelists to have them introduce themselves? Yes. Thank you.
I'm Ella Kazerooni. I'm a cardiothoracic radiologist at the University of Michigan. So I really appreciated all the structural heart disease this morning. Disclosure, my husband is an interventional cardiologist. Usually say that at radiology meetings. And I'm also the chair of the American Cancer Society's National Lung Cancer Roundtable, which has a goal of creating lung cancer survivors with a strategic component clearly focused on early detection.
Hi, my name is Vliegenthart. I'm a cardiothoracic radiologist as well from Groningen, the Netherlands, and I focus on early detection of disease. I'm involved in the Nelson study and lead a population-based study where we determine reference values in the general population called IMALIFE.
And Javier?
Zulueta, pulmonologist. And by the way, we're equal not only in women and men, but also in pulmonologists and others.
We're equal opportunity.
So I'm a chief of pulmonary and critical care at Mount Sinai Morningside, right on the other side of the park. And I've been involved with lung cancer screening and with the I-ELCAP group since 1999. First met Claudia.
Yes. So to just get started, we have a series of questions. I'll pose the first one, which is, what other lung diseases? We've heard about emphysema, lung cancer, bronchiectasis, and what other lung diseases could we potentially evaluate in a screening setting that have mortality implications? Javier?
Pulmonary hypertension. We can see on the CT scan, just by measuring the pulmonary artery, we can find the signs of pulmonary hypertension, and the prevalence is not that low. I can't quote numbers right now, but and many of those who have a pulmonary artery greater than 3.1 centimeters are at risk of having heart disease. So,
yes, okay, great. So the next question, in addition to what we've already heard from the initial comments, what interventions are actionable today in terms of these kinds of findings that we're discussing? Ella, want to start off?
Yeah, would you mind popping up the couple slides that I have? Because I think it'll make that clear in this bigger COPD space that is somewhat amorphous. It's not well studied and we really don't know. Yeah, you could go to the next one.
Next slide, please. You want the...
So we really do not understand COPD in the way cardiovascular medicine understands ischemic heart disease and atherosclerotic coronary disease. We are several decades behind what has happened in the cardiovascular community to understand the disease state. And it's taken, I would say, the last couple of years and some major NIH-funded studies to try and understand what COPD really is, what its disease phenotypes are clinically, and importantly with an imaging component. And these two studies, COPD gene, started in 2007, and we're now on the fourth round of serial high-quality CT imaging to collect information on patients. And Spiromics is another multi-center large study. So these two studies funded by NIH are using serial high-resolution quality imaging to look at lung disease to help us understand it better in the way you understand atherosclerotic coronary disease, both clinically and to phenotype the disease. And phenotypes drive treatments and clinical trials and better patient outcomes. And this model was just published in the Blue Journal, which is the Pulmonary Medicine Journal, just this month. It's still online ahead of print. And it takes this wealth of data in COPD gene and tries to figure out what is this kind of COPD thing that we talk about so loosely. And we hear comments like emphysema is not COPD. But isn't it just preclinical COPD? Isn't it subclinical disease instead of it's not COPD? And so this model has taken a lot of data from these serial CT patients. This was almost 9,000 patients. and use this, maybe a little bit hard to understand graphic. These are pictures of different phenotypes of COPD based on clinical symptoms, based on imaging data, based on patient-reported symptoms and outcomes, to try and understand that it is really complex. When I was in med school, it was emphysema, asthma, and chronic bronchitis, and that was very simple and straightforward, and people thought they might have known what they were talking about, but it's so much more complex. And these subtypes, as you can see here, they're much more detailed and broken down in the way patients respond and their symptoms. Next slide. Next.
Yeah.
And what we've been able to show is that people's phenotype of disease changes over time. There are people who are emphysema predominant patients who stay that way. There are patients with small airway disease who morph into emphysema and chronic bronchitis. It's a much more complex disease state with lots of inflammatory things happening in the lungs, with pulmonary vascular changes we're seeing are happening. So it's much more complex. This chart at left shows you the patients who are stable over 2 time points, and all the patients at the bottom who have changed their phenotype of disease. And so treating somebody today and treating somebody in 2 years or 5 years may look very totally different if we don't understand this better. So people are moving across these phenotypes. Can you click one more, please? And this is just looking at the people who change. Look at all that crosstalk between 1 time point and a second time point. Just a couple of years down the road, they're changing their phenotypic expression. Next. And then we're trying to drive this into how can we identify the genetic underpinnings, the proteins to drive drug discovery and target different phenotypes. And this is just one example of taking this phenotyping and matching it to proteomic predictors. So we have so far to go in COPD to understand it. A little bit of emphysema is not no COPD. It's probably just subclinical disease, or a little bit of small airway wall thickening, or a little bit of mucus plugging. It's all disease that may not be symptomatic, that we don't even really understand. And the next, I'm almost done, sorry. I did want to show this, sorry for a plug for this, but we talked about patient level reports and impact of like seeing their coronary calcium and talking about it. You can do the same thing in lung cancer screening and take all of the things you can see on the screening CT and put them into a patient-centered report. And this was just a study we did with this report with a group in Minnesota as well, to look at if you show them information that's real based on their own CT, and you tell people what it means to them, what would happen if they quit smoking physiologically, functionally, future state health, it does increase the likelihood that they're going to quit smoking and have more quit attempts. So I think this is really powerful information. It was said before about calcium. And I think one more. Yes. So this is also just out in print, which is leveraging CT. And I think while you've seen all this conversation today in the cardiovascular community and where you are in moving this frontier, the respiratory community is behind in pushing this. And this is really the first major paper, also in the Blue Journal, multi-country, really putting it on paper and saying that the lung community needs to leverage this as well. And so I just want to make that important point. There's so much in there, but we have to get our communities on board to recognize it.
Yeah.
Okay, I'll stop there.
So to make your comments even more complicated, the leading cause of death in individuals with COPD long-term is cardiovascular disease. So this is a bowl of spaghetti. And so the next question that we had was, what interventions? Okay.
So thank you. This is great. Question, should we do exploratory CT as part of lung cancer screening?
Yeah, so this is a really important question. All that COPD gene study data is inspiratory and expiratory CT, high resolution, really good quality, trying to get the best information. Can we do it low dose? We've been modeling low dose CTs and standard dose CTs to be able to try and extract the same. But also, would you add, so as you're talking about expanding the rest of the chest in a coronary calcium CT, would you add an expiratory CT to get the more powerful information from the lungs that you don't currently get? And so as we think about it, we can think more holistically, both from the cardiac and the lung standpoint. Yeah, I agree.
So you have a two-step process. So when you see that first one, so don't equate it immediately with screening. You do the first.
Yeah, but this is the transition that we're talking about. Screening is a screening test, And then it's a gateway to diagnostic tests that work up various findings from screening. And so this is the bucketing we have to do for the primary care community and for the people at large to try to map what the information from screening is and how do we apply it. So in that spirit, can we move on to,
Oh, it's a missed opportunity when they come for screening.
I would-
Doing an expiratory sequence at the same setting is 5 seconds.
no, that's
And
not
the
true.
information-
Ella, I would do a spirometry before an expiratory CT.
Bingo.
But the
That's right.
problem is you
You're all
don't,
three of the pulmonary.
you have to then,
Perfect
We're
is
not
the
biased.
enemy of the good.
But you could link it, right? If you see something characteristic on the low-dose CT, you could,
the problem is you don't get the information. So when you do expiratory CT,
That's
you
why they
see
have no
things you didn't
guidelines.
see on the inspiration. And so you don't know what you don't see unless you do that. And that's that whole small airway disease cohort that COPD gene has been identifying. You don't see it on an inspiration exam.
Okay, so I'll bring you back to Ella, to your comments about tobacco cessation, okay? Because that's something that could be done now without U.S. Preventive Services Task Force dithering any further. So what other things are in that bucket of actionable interventions at this point in time? And that's the next challenge to the panel. Who wants to go first?
I think it's going to vary depending upon what the finding is. For bronchiectasis, it's referral to a specialist. For obstructive lung disease, maybe an expiratory CT, maybe spirometry. Ultimately, it's going to need action, but for bronchiectasis and probably ILD, even the primary care doctor isn't going to know what to do.
Well, in the paper that Dr. Rizzo quoted from the New England Journal on the Canadian study on COPD, the intervention that they used that they felt was most efficacious was the doctor telling the patient to lose 5 to 10 pounds, which I think you could do right now. But, okay, but see, but, you know, just getting vaccinations, you know, that are scheduled. I mean, there's a variety of things. And so we have a block. If there's a drug, the drug companies tell us, well, think about that. But there's all these parameters of disease, you know, social determinants of disease that we heard about from Dr. Harrington, that we are kind of paralyzed in terms of underscoring, not in the population. The paper that you showed is a general population. This is in a screening population in which there's a vastly higher risk profile than the general public. And so our abilities to kind of get more proactive in terms of interventions is something that is a big opportunity.
Their physicians are drowning in activity. Their nurse practitioners and PAs are seeing the simple patients. They're seeing the most complex patients with the most comorbidities, and they're under tremendous stress. And so when we put things on our radiology reports, which I encourage radiologists to report coronary calcium, to report any emphysema, to report all these things, what we get back from primary care is, well, what's the next step? Can you articulate for them in a very simple, pragmatic, algorithmic approach what they can do? They can build that into their EHR and their health maintenance activities and make prompts to do it, but they need to know what to do, because telling people to, radiologists, put in your reports. Okay, that's great, but somebody's got to do something with it. And is that referral to a specialist in ILD? That's like with a pick list in our radiology report. Unsuspected ILD, refer to pulmonary medicine to get PFTs. Same thing with bronchiectasis. But if you don't know that for all these other findings, like, okay, there's some mild airway wall thickening, or there's some mild emphysema, is there an action item? When does there become an action item? And they're really needing assistance, because some of it is in the primary care domain and some of it's in the specialist
No, I
domain.
think you're right. I think you're talking about implementation science. Really, the system change. A lot of practices are not efficient at what they do with regard to guideline care. They may have the manpower to do it, they just don't know how to do it. And insurance companies are starting to pay for that to occur. Lung Association has some projects where we go into the practices for asthma guideline. And I think that takes some burden off the primary care doctor. But I also think somewhere in between, we need not a pulmonary specialist, but maybe a mid-level who is like a respiratory therapist who's trained in some pulmonary medicine to go over some of these reports with patients and then figure out what's the next step for them. primary care doctor to do if he's not going to send it to a pulmonologist.
I think, Al, and I think from seeing your fantastic presentations, all three of you, you all three show that there's great promise for therapies for early disease. In ILD, we know that, you know, the current therapies just stop the progression. So intuitively, you would think the sooner you start, the better, right? You have to do the trials and all that, but there's a potential treatment there. We just saw a potential treatment for bronchiectasis. And we're talking about prevalences. Bronchiectasis is 20-some%. Emphysema, we know that's 30% in our cohort in the University of Navarra, and in I-ELCAP at large, it's about 28%, I remember. And we just heard, you know, potential therapies, trials that are coming out with the longevity modulating medications like metformin and things like that. So we might have treatments for early disease. So we might have to start. And I think, by the way, this is going to change we're going to solve our big problem that if you read anything about lung cancer screening today, the main problem is that implementation rates are below 10%. We're terrible. Well, pharma is going to take care of that. I mean, with all these treatments, I'm sure that we're talking about 20 to 30% prevalence of these diseases that can be treated early. I think lung cancer screening is going to take off, and we have to start referring to specialists for those treatments.
I think the other aspect of this is that patients are becoming very familiar with their reports, and it's not uncommon for us to receive a patient who read about this little bit of pulmonary fibrosis, and they are the motivating factor that it's coming in. They want their PFDs done. They heard about their family member who had pulmonary fibrosis, and they want a low-dose CT scan to see if they're affected. So I think that that's an area where we can do much more in educating our patients as to, like you're doing, with a report that tells them what it means. Okay, and what they can be done for it.
You know, one of the things that I've noticed, and I've been looking at it a little bit more carefully, is that, and most recently with bronchiectasis, is that not all bronchiectasis progresses. And Maria, you was alluding to this, but we looked at bronchiectasis, mild, moderate, and severe. And even the moderates and the severes, about 15 to 20% seem to stabilize. They just don't, and the milds also, some 20% of them don't seem to progress. So, you know, it raises the O word, you know, the overdiagnosis word. But we're seeing this in the ILDs, you know, everybody, ILD from the time of diagnosis to death is, you know, a couple of years. Well, we're seeing some ILDs that seem to be stable. I haven't quantified the ILDs as much. We're going to do that at some point. So I think we're seeing this early disease. It's a very interesting interactions, and emphysema, the same thing. Not all emphysema progresses. We're going to look back, you know, we have 30 years of CT scans on some population that have been coming to us. So we're going to be looking more carefully at this. But this to me is a really super area to figure out why the diseases progress in some and not in others.
You have to also take into account the biomarkers that are associated with any of the diseases, just like their genetic predisposition to the underlying disease. So an ILA in a patient that has MUC5B mutation, you know, you pay more attention to that patient. And the same thing for other diseases. There are going to be these biomarkers that my dream is that I'm going to have a fibrotic panel. I pick this one out, just like I do connective tissue disease, and I check the ANA and I checked all the other biomarkers that are there, that I'm going to have one for the progressive IPF or the progressive pulmonary fibrosis, together with the imaging, together with the physiology, together with the history of the patient that is so critical.
Just one response, David. We want to be careful that we're not suggesting that lack of progression is overdiagnosis, because many of these patients, even if they're not progressing, are symptomatic, unlike someone with a 5-millimeter nodule that doesn't progress. But it'd be nice to correlate that. It's a really important question.
Also, I think one of the things we suffer for in radiology is when abnormality is mild, it's hard to visually see if something's changed. And so you can have somebody saying, there's mild upper lobe central lobular emphysema for 15 years. But if you actually quantify that emphysema, it has changed a tiny bit every time over those 15 years. And that longitudinal progression of early disease is often completely unrecognized. We've had an emphysema quantification lung volume tool running for about 12 years now. And if I just look back at the last one or two ago, 1%, 1.2%, doesn't change a lot. But when you look over 8 years and 10 years, and you start to put that in your report, now it's more powerful because now you're saying it's not only there, but over the last 10 years, it's gone from 2% of their lung tissue to 7% of lung tissue. You've defined a morphology and a prognosis because of progression. But if you just go to the last immediate chest CT, or maybe just one before, that ILA might not have changed, that emphysema might not have changed, but that longitudinal progression, I think, is really important
so
in lung
important.
disease.
So to all our engineers in the audience, we need better measurement tools.
AI.
Just a thought for you guys. One of the things that, and Ella, you kind of hinted at this, maybe not hinted, we're more overt, but there are guidelines out there. For example, and you look at the U.S. Preventive Services Task Force when it comes to COPD and screening for COPD, they say don't do it. Not only is it not recommended, they actually say that it's harmful to do it. It's an interesting point, right? Harmful. So now we have screening, and in all essence, we still are screening for emphysema. You can say we're screening for lung cancer, but every single report I comment on emphysema. So in all essence, I'm screening for emphysema as well, even though the U.S. Preventive Services don't do it. I think, this leads us to this idea of, you have the patient on the table. He's already there. Ella was pushing, maybe we should get expiratory scans, and Rosemary was saying the same thing. Mort is pushing, he's on the table already. He's got the cardiac scan, open up the field of view for sure. And that's still not being done. Still, in major academic institutions, they're doing coronary calcium scoring, and they're not even opening up the field in the area that was scanned.
Even though it's in the SCCT guideline to use a wide field of view, they still don't do it. It boggles my mind. And even though there's been series after series of papers published about the number of lung nodules and lung cancers that are missed because people are just coned down to the heart.
And so Mort is pushing us. Mort is pushing
Here's
us.
fear. I just presented at the American Society of Nuclear Cardiology this very issue because it's both a patient care issue, it's a institutional risk issue. I'm also a kind of an administrative oversight of all diagnostics for our health system. And when you look at the different issues around it, you can't ignore the fact that people can have lung cancer outside that little field of view that's going to impact their life and their families. There have been lawsuits that have been filed and settled around this very issue. To not do it, in my mind, is medical malpractice.
Really? Well, and we have to also think then, while he's on the table, do we just go up that couple of centimeters more and cover the rest of the lung? And we'll hear all about the pushback for this, all the harms we might be causing. But to me, this is an obvious thing that we should be doing. Okay,
Sorry,
I
David,
think,
vice versa. Calcium scoring, or at least the amount of coronary calcium on any chest CT, is also not done in the majority of people and not in clinical scans. So I think if there's one message, do it starting tomorrow. This is something we can all do, right?
I heard something about in your country, they don't even allow you to report the calcium score. Is there some truth to that, Ruben?
No, that is for a very specific screening study.
Oh, okay. Just checking. Okay, I think we're. You have you have 2 or 3 experts right there.
I'll start. I think the first thing, if they've not had pulmonary function studies, get that done. I mean, we know, well, that test is going to tell them if they have defined COPD, okay? And it's going to at least trigger potentially an evaluation by a pulmonologist. Well, I think that's where we need. That's a great study, because I think if an emphysema is seen on that CAT scan, maybe the radiology department should have one of those simple portable spirometers. Here, blow in this before you leave and get a value.
Wow, I
That could
can
be a
tell you-
study.
very
I can tell
interesting.
you the data that we found that in Navarra and the University of Navarra in Spain, we had 30% of individuals had emphysema and 28% of individuals independently had COPD. But there were 15% of the emphysema patients that had no obstruction in their spirometry. So in general, and you know, I have some opinions because no evidence whatsoever about is it early disease or is it a different disease. I kind of think that emphysema is a whole different disease than the chronic bronchitis, but that's not for this discussion. But there is evidence that so there is emphysema without airway obstruction, but they have limitations. You do physiologic studies on them, you do 6-minute walk tests, and they desaturate, they walk less, they're symptomatic. And then the risk of lung cancer is 3-fold greater.
So I think one of the,
Women.
so it's really interesting when radiologists are asked about reporting emphysema, and many of them say, well, what's the value when reporting mild emphysema? You know, 1, 2, 3% of the lung is there. There's no treatment for it. Spirometry is usually normal. Why should I even report it? In the ACR's lung cancer screening registry, we've got about 7 million lung cancer screens in there with lots of serial data. And when we looked at the first sort of 1.6 million screens, 62% of people have at least 62% of the people with a significant incidental finding had coronary calcium. That was the number one. But the second most common is lung disease. It was about 5% had some form of interstitial lung disease, but only 2.2% of people reported as having emphysema, because radiologists only think it's significant if it's moderate or severe, like extensive tissue damage. You know, 20% or more of the lung parenchyma. And if a couple percent is actually preclinical disease, changing the mindset about radiologists, changing the mindset about pulmonologists as well, and primary care physicians to know it may not meet the threshold for COPD by diagnosis now, but it is a risk factor for lung cancer. And it is something that maybe we should be watching more closely.
And because of that, the last thing you said, if in a lung cancer screening program, compliance is an issue as well. We know that you know, less than 50% of the people come back for a second CT. If there's one patient you really have to call today with the data that we have, the biomarker, the strongest biomarker for lung cancer risk is emphysema. So that's the patient you really want
Yes.
to have come
Okay.
back.
Okay, so
Dr. Aguayo, I think.
we're out of time. Sam, you got the final question.
That's a
Okay,
big,
thank you.
really small comment, which is the approach to incidental findings is so very different in the US than in other countries. So we report everything. That's kind of what we're kind of taught to do. In the UK implementation of lung cancer screening, they only report certain incidental findings back to the primary care physician, and they don't report the rest. So mild coronary calcium doesn't get reported back to the PCP. Mild emphysema does not get reported back to the PCP because there's no action item for the PCP to take, is the way they frame it in their national health system.
Okay, so stay tuned, show up tomorrow. We'll take up that very subject. Thank you all for a very, very, you know, passionate interaction on an important topic that shows the importance of why we're all here. Thank you very much.